Hello, everyone. Thank you for joining. In today's session, we're continuing on with neuro-ophthalmology, and we're looking specifically today at ischemic optic neuropathy. So I'm going to cover both anterior and posterior. We'll talk about the different presentations, the different causes, and the management of these conditions. Now, in the sort of casualty setting is where you'll mostly see these patients. They typically present with sudden vision loss. Um, and for most of the patients that you're going to see with ischemic optic neuropathy, it will be non-arteritic anterior ischemic optic neuropathy, which is, painless vision loss with usually no other clinical symptoms. So they're typically presenting straight to the ophthalmologist. And this is where you'll see these patients, and it's important to sort of know what it is you're looking at. So starting off with anterior ischemic optic neuropathy, it's divided into sort of your two types. So you've got arteritic and the non-arteritic. Now, the vast majority of the cases that you're going to see is going to be non-arteritic ischemic optic neuropathy. It makes up about 90 to 95% of the time of the cases you're going to see, but about 1 in 10 of them will be arteritic. And of the arteritics, the vast majority are going to be GCA. There are other causes of arteritic optic neuropathy, but the vast majority are GCA. And then we'll also talk about the different causes of non-arteritic ischemic optic neuropathy as well. We'll start off with the arteritic. Like I said, the majority are caused by GCA. There are other sort of differentials to think about if some of your investigations are coming out negative, and that includes things like Takayasu's, GPA, PAN, for example, polyarteritis nodosa. So there's different causes of an arteritic anterior ischemic optic neuropathy, but the majority will be giant cell arteritis. Now, you have to remember that this is obviously an ophthalmic emergency, it's life-threatening, and your patient is typically going to be an over 50-year-old coming in with a new headache, some tenderness to the scalp, and there are certain investigations that will go into a bit more detail that will be positive. The thing to bear in mind is GCA is vanishingly rare in patients who are under the age of 50. So when you're seeing a 40-something-year-old or a 30-something-year-old, it's really very unlikely for it to be GCA. There are other reasons why they may have sudden vision loss and headaches, but it's not going to be GCA in a patient who's that young. And even though it's very rare in the under 50s, it's actually typically 70 and above where you're going to see something like this. And in the 50s to 70s, you're actually usually looking at non-arteritic. They tend to be a slightly younger crowd. But for GCA, you're usually looking at the over 50s, but more typically, it's actually older as well, so over 70. Your features, they can either actually sometimes be seen by you before they start to develop ocular symptoms. So they can start with the headaches, the temporal tenderness. This can go on for a few weeks, some jaw claudication. And in that process, they can sometimes have symptoms of transient visual loss. So that can either be obscurations, kaleidoscope type symptoms, almost things like ocular migraines. And then also actually amaurosis fugax. And then once they actually have ocular GCA, full-blown arteritic ischemic optic neuropathy, they'll have a sudden vision loss, and it will actually be quite a dense vision loss. So they'll typically come in with vision less than 1 logMAR, and they'll really have quite dramatic vision loss in that eye. They'll typically have an RAPD, and then when you're looking at them, as I showed you in this picture before, you're looking at a swollen optic disc, maybe some peripapillary hemorrhages, some cotton wool spots, and essentially a very typical picture of an anterior ischemic optic neuropathy. And that vision loss sometimes is a nice way of just immediately, when you're looking at your patient, deciding what you think might be going on. Is arteritic anterior ischemic optic neuropathy tends to be very, very dense vision loss when compared to your non-arteritic causes. Now, when it comes to investigating GCA, there are things that you're going to have to do immediately. So you're going to want to send off some bloods. You're specifically looking at ESR and CRP. Typically, your ESR is pretty raised above 50, but it doesn't have to be. Your CRP tends to be a bit more sensitive than your ESR. So your CRP will sometimes be raised either more so or not necessarily in the context of an ESR, but your is a bit more specific. And you might also want to consider doing a full blood count, some liver function tests. A lot of that is about the fact that you're about to start these patients on high dose steroids if they do have GCA. And importantly, they're going to be negative for the autoantibodies. So things like ANA, ANCA, those things are not going to typically see in the blood because they tend to point you towards a different diagnosis. Now, typically, when you're getting the involvement of your rheumatologist, they will usually ask for an ultrasound or essentially a Doppler of your temporal arteries. And that gives you a sort of this kind of hypoechoic halo around the artery. And that actually tends to be a very sensitive way. And the recent research suggests that it's as sensitive as a temporal artery biopsy. So that tends to be what people now do. You very rarely now see somebody having a temporal artery biopsy. Um, Temporal artery biopsies nowadays are usually done in the context of somebody having had a high ESR, a high CRP, symptoms suggestive of GCA, no sort of clear ocular findings, an ultrasound that is inconclusive. And these are patients that will therefore go on to have a temporal artery biopsy. It remains the sort of gold standard in terms of its sensitivity and specificity for the disease, but you typically don't really see this very much, at least in the UK. So the general guidance is depending on what you read, some guidelines will tell you 1 centimeter, some will tell you 2 to 2.5. The important thing with a tab is that you're not delaying treatment. These are patients who are still going to be started on steroids. You're not waiting for the results of a biopsy. And your biopsies, if they've started the steroids, if you're doing your biopsy within a few days of starting the steroids, you still have a pretty good sensitivity from the biopsy. So if you're doing it within 2 or 3 days, you're still okay. Some people will tell you up to 2 weeks from starting steroids, but you have a few days once you start the steroids to still have a pretty reasonable chance of getting a positive result back from your biopsy. And in rarer cases, you may even consider doing some large vessel imaging or imaging of the shoulder and spine if you're thinking that this is a patient who's got polymyalgia, and just having background imaging done just to kind of deal with an underlying condition. But ultimately, GCA will be diagnosed clinically, in the symptoms that the patient has, the examination of the patient and the age, and then secondarily either by bloods or the ultrasound, and in rarer cases, like we said, the biopsy. So the management, you're going to really start off with just steroids. Now, if you have somebody with GCA, but they don't yet have ocular symptoms, they usually started on about 1 mg per kg of oral steroids, and then they slowly taper down. But if somebody in front of you has an arteritic anterior ischemic optic neuropathy, you're going to want to pulse them initially with some steroids. They'll get anywhere between half a gram to a gram per day for about 3 days. They'll then go down to a high oral dose. And then you'll start to taper them from about 50 to 60 mg per day, down over several months. So, for example, they'll go down by about 10 mgs until they get to 20 mgs, and then they'll go down by 2.5 mgs every few weeks until they get to 10. And then from 10 milligrams down to zero, they go down by 1 mg, again, every 1 or 2 months. So, these are patients who are going to be on steroids for almost a year and a half, even up to 2 years, and sometimes even longer than that if they relapse. Remember that these are patients who are going to need some stomach protection. There is some evidence that suggests that antiplatelet therapy can help. So sometimes patients are started given 600 milligrams stat, and then they're given 100 milligrams a day. And research has essentially shown that it does help to reduce vision loss and stroke. And these are generally in the management of GCA. And in terms of immunomodulators, so if you're thinking about trying to use some steroid-sparing agents, methotrexate is usually used as an adjunct to steroids, but biologics haven't really yet been found to be of any benefit in the context of AAION. They're going to be starting them on steroids, so they need their bloods, they need their sugars sort of monitored, they'll need their bone density monitored. And like I said, these are patients who are typically managed within rheumatology. And then as the ophthalmologist, you are then examining the patient and following them up from a vision point of view within your ophthalmology. But the mainstay of the management tends to be with rheumatology. So, a quick comment on the temporal artery biopsy. You're usually marking where the artery is along the hairline. You might want to use an ultrasound to actually locate it. You then dissect down. You want to be kind of careful with your delamination. You don't want it to bleed because it can bleed very, very heavily. So you want to be really careful with actually trying to locate your artery in the first instance and then not actually accidentally puncture it. And then when you find a part of the temporal biopsy, temporal artery, you're then going to clamp or ligate each end with a suture, for example, and then you remove it and you just close up. And like I said, it's important to try and get a good 2 centimeters of this because of the skip lesions, which means you're just increasing the likelihood of actually getting a positive histopathology report back. Now, the prognosis of AION is pretty poor. These are patients who come in with dense vision loss. They have very, very little gain, even with prompt treatment. But the important thing to bear in mind is the reason you're treating and the reason you're actually telling these patients about treating is because there's a risk to the second eye and a risk to life. Without treatment, there's up to a 95% chance that the other eye gets involved. And with treatment, that drops dramatically down to 10%. So there's a clear benefit in actually managing these patients. But also, these are patients who have essentially an arteritis of the large vessels, and it can happen anywhere. So these are patients who are at risk of strokes, they're at risk of MIs, they're at risk of mesenteric artery occlusion, which essentially just causes widespread bowel ischemia. And ultimately, actually, sometimes these are patients who are at risk of death. So managing GCA is incredibly important, being able to um, recognize that the patient in front of you might be somebody with GCA, getting prompt investigations and starting management based on a clinical diagnosis is key. So moving on to the non-arteritic, these are patients who have an occlusion of the short posterior ciliary artery. So what essentially happens is that the optic nerve head starts to die. Now, why that happens, usually it's more risky in patients who have very small congested nerve heads. It's associated with your usual cardiovascular risk factors, things like hypertension, diabetes, hyperlipidemia, smokers, for example. And there's also associations with thrombotic diseases like antiphospholipid syndrome, for example. And that picture on the left-hand side gives you a typical example of what a non-arteritic uh, AION looks like. You've got this kind of swollen discs and peripapillary hemorrhages, but typically here the disc is actually hyperemic compared to pale, which is what you'd ordinarily see in the in arteritic AION. So these are patients who are going to come in with painless vision loss. And one of the differentiating features between non-arteritic and arteritic is, again, the density of the vision loss. Non-arteritic anterior ischemic optic neuropathy doesn't tend to present with such a dramatic drop in vision. And like I said, they also tend to be slightly younger. So as I said at the start, NAION tends to be, your 50s to 70s, whereas the older patients are more likely to get well, not more likely, but essentially you're typically seeing GCA in a much older population. Like I said, you'll have a swollen optic nerve. They tend to be more hyperemic than pale. They may come in with altitudinal field defects because of how the optic nerve head starts to die. They'll have an RAPD, for example. And again, importantly, these are patients who are going to have normal bloods. They won't have a raised ESR. They shouldn't have a raised CRP. And that's what, again, will help you differentiate between these two patients. Now, if you're seeing somebody in front of you with a swollen optic nerve and all of these sort of features, and it's completely painless, the risk of it being GCA is pretty low, but it's still worth sending these patients off to have a blood test and just make sure you're not missing a giant cell arteritis, because sometimes patients may not necessarily tell you that they have a headache and you haven't asked, or if they haven't admitted to it, then it's still worth getting those bloods in case what you're looking at is actually arteritic and not non-arteritic. There is no proven treatment, unfortunately, but the studies suggest that essentially patients can slowly improve. About half of patients will actually slowly improve over the coming weeks to months, but there is a proportion of patients, up to about 10 to 20%, who will actually continue to drop in their vision. So the prognosis is pretty difficult, but these are patients who are going to get follow-up. And essentially, you're trying to counsel your patient and letting them know that time is essentially what tells us how bad this can be and how bad it will be. But unfortunately, there is no proven treatment. Some patients, some places have tried sort of like optic nerve fenestration, for example, or giving aspirin. But nothing has really been proven to actually benefit patients with non-arteritic anterior ischemic optic neuropathy. So finally, I wanted to talk about posterior ischemic optic neuropathy. This is much, much rarer. You're not typically going to come across these patients. And what essentially happens is that you have the retrolaminar optic nerve dying. And what's important here is that these are patients who are going to present perhaps similarly to something like an optic neuritis. So you need to be excluding those sort of other causes of a retrobulbar optic neuropathy. And I've spoken about some of those in the optic neuritis talks, if you want to have a look at that as well. So the main causes of a PION, the majority of the patients with PION will typically have had some sort of hypovolemic insult. Now, that tends to either be peri-operative. So, for example, somebody's had major surgery, heart, spinal, orthopedic surgery, and and they've had a sort of hypovolemic, hypotensive episode during the surgery, and then when they wake up, they suddenly realize that they're not able to see, or they've had trauma, for example. There are arteritic and similar non-arteritic causes causes to PION. So again, the hypertension, diabetes, hyperlipidemia, these are all things that can contribute. But typically, PION tends to be patients who have come in with a hypovolemic insult. They tend to present with sudden visual loss with RAPD, but remember, because someone has had a hypovolemic insult, it can happen bilaterally, in which case you won't necessarily see an RAPD. Um, and the optic nerve, importantly, is normal, or at least it looks normal in the early stages because everything has happened retrobulbar. Now, unfortunately, these patients present with really quite profound vision loss, and if it is bilateral, um, unfortunately, the prognosis is quite poor. Now, for those who have had a hypovolemic insult, prompt fluid replacement can sometimes help. But unfortunately, PION actually carries a pretty devastating prognosis for these patients. So, really importantly, good documentation, a clear sort of letter that actually describes exactly what's happened. Um, and really with PION, you want to get your sort of seniors involved because in the context of it being sort of hypervolemia or in the context of it being peri-operative, these are patients who are going to be very, very upset. And sometimes actually there's even like medical legal consequences. So um, do make sure that you are kind of examining the patient properly and getting a senior review where you can. Sometimes, and a lot of the time, these patients are not necessarily consented for this complication. So, and with the recent law change in the UK about what you need to consent your patients on, it is important that these patients understand sometimes, but that's obviously, they're usually going in for a non-ophthalmic surgery, but they end up in your clinic afterwards. So careful documentation, careful examination is key with these patients. So just to summarize then, we've spoken through ischemic optic neuropathy, both the anterior and the posterior. And essentially what the main thing to bear in mind is that there's lots of different pathologies that can lead to an ischemic optic neuropathy. And importantly, some of them are life-threatening, so it's important to have those in mind. It's important to be able to differentiate between arteritic and non-arteritic, and then also knowing what investigations to send off and what to do if they come back positive. And importantly, the prompt management. Patients who have suggestive features of GCA but not yet ocular symptoms, you can save their sight by managing the GCA with steroids. And if they come in with change in their symptoms, sometimes some neuro-ophthalmologists I know will have a pretty low threshold to pulsing a patient, even if they haven't necessarily had, florid ocular GCA. If they've got something that's pretty convincing in the background or a known diagnosis, and they have even the flutter of a visual symptom, some people I know will uh, pulse these patients to try and save their sight because once that sight has gone, it's gone and it won't be coming back. That brings us to the end. Thank you very much for joining. Please do remember to fill out the feedback. There's a link in the description. Thanks again for joining, and we will see you at the next one.